Hello everyone, welcome back. Today I'll be covering journal number 4, Anatomy of the Anterolateral Ligament, ALL, of the knee joint. My note, this journal is from World Journal Clinical Cases by Junggu Park et al. 2022. Now let's get started. As an introduction, the anterolateral ligament ALL is discovered as a new ligament structure as well as its potential role in the anterolateral rotational stability. ALL has been described as the anterior band of the lateral collateral ligament LCL, the mid-third capsular ligament, the anterior oblique band, and the capsular osseous layer of the iliotibial tract in the previous study. To present the anterolateral structure that tightens during the internal rotation of the tibia between 30 degree to 60 degree of knee flexion. After the rediscovery of ALL, its clinical significance was demonstrated in several biomechanical studies, suggesting that it's possible associated with the rotational instability of the knee joint. Even after successful ACL reconstruction, some patients complain of residual anterolateral rotational instability (ALRI), which present with persistent pivot shift test. ALL reconstruction is considered as an alternative option to control ALRI in ACL injury patients. Many studies have shown that ALL reconstruction combined with the ACL reconstruction significantly decrease the rate of ACL retear and ALRI, in addition to improving patient-related outcome. Historical review of ALL. In 1879, Paul Segond described a purely resistant fibrous band which invariably showed extreme amounts of tension during forced knee internal rotation, and suggested that this structure is related to avulsion fractures in the tibial anterolateral aspect. Segond fracture is recognized as a pathognomonic sign of ACL injury. This figure shows a plain X-ray showing a second fracture that is noted post-ACL reconstruction. You can see there's an endo button there and tunneling done for ACL reconstruction. And there's the second fracture. ALL was first named by Vincent et al. In 2012. In 2013, Claes et al. Identified a well-defined ligamentous structure ALL that was clearly distinguishable from the anterolateral joint capsule in human cadaveric knees. In a subsequent study, the tibial insertion site of the ALL on a cadaver was compared with the location of the second fracture on MRI images, and a high correlation between the two locations was demonstrated, which suggested that the second fracture is a bony avulsion of the ALL. This cadaveric picture shows the anterolateral ligament ALL. The current consensus is that ALL exists at the anterolateral aspect of the knee joint in the most people, as a distinct ligamental structure that tightens when the tibial internal rotation with 30 to 60 degree knee flexion is applied. Anatomy of the ALL. Talking about anterolateral complex. The structure related to the anterolateral aspect of the knee joint constitute the anterolateral complex. This complex consists of the superficial iliotibial band and iliopatellar band, deep iliotibial band, the capillum fibers, retrograde condylar attachment continuous with the capsulo-osseous layer, and ALL. The layer 1 is illustrated. This includes the superficial iliotibial band, SITB, and iliopatellar band, IPB. The asterisk indicates the folding of the posterior part of the superficial iliotibial band at higher degrees of knee flexion. GT is girdis tubercle. Anatomy of the ALL. The first layer consists of the superficial iliotibial band, the second layer consists of the iliopatellar band, and the third layer is comprised of ALL. Within the third layer of the anterolateral capsule, the ALL is the superficial lamina and the deep lamina is the true capsule of the knee joint. ALL is anteriorly merged with the anterior capsule and posteriorly close to the lateral collateral ligament. The first picture shows the posterior reflection and distal release of the superficial iliotibial band, ITB, reveal the obliquely aligned fibers of the middle layer of the iliotibial band. As seen, these fibers could be best seen in the supracondylar region. The label DITB is a deep layer of the iliotibial band. The second picture shows an isolation of the anterolateral ligament, ALL, the black arrow, in a cadaveric right knee joint. The asterisk indicates the lateral epicondyle of the distal femur. The length of ALL reported varied from 30 mm to 59 mm. The length of ALL increased with knee flexion and tibial internal rotation. The thickness of ALL varies from 1 to 2.5 mm and the width of ALL varied between 4.0 to 7.0 mm. For proximal attachment site, the femoral origin. The current consensus is that the femoral origin of ALL is typically located proximal and posterior to the lateral femoral epicondyle. This figure shows the anterolateral complex of the knee. ALL shows anterolateral ligament. FCL shows the fibula collateral ligament. GT is lateral gastrocnemius tendon. ITB is the iliotibial band. LE is the lateral epicondyle. PLT is the popliteus tendon. For distal attachment site, the tibial insertion. The tibial attachment site of ALL is located halfway between the Gerdy's tubercle and the tip of the fibula head. The tibial insertion site of ALL is around 5 to 10 mm below the lateral tibial plateau. For the meniscal attachment, Hileto et al. Demonstrated that the meniscal insertion of ALL was located between the anterior horn and the body of the lateral meniscus, specifically beginning at 36% and ending at 41.9% of the circumference of the lateral meniscus. Imaging of the ALL. MRI is the most useful tool, especially coronal and axial proton density sequences with fat saturation. The lateral inferior genicular artery is a reproducible landmark for identification of ALL. On coronal images, this artery is seen as a small dot and the meniscal attachment fiber of ALL is easily found proximal to it. Just below the lateral epicondyle, ALL can be found as a long, thin, low-signal ligamentous structure that runs distally deep into the iliotibial band and anterior to the lateral collateral ligament. Several studies using MRI have shown a high rate of ALL in the ACL injured patient, which ranges between 40% to 80%. These coronal magnetic resonance images showing the anterolateral ligament, the white arrow, which is attached to a second fracture fragment. The white arrow head indicates a second fracture. What is the role of plane radiograph? Its role is helpful in the tunnel placement in ALL reconstruction by identification of the femoral and tibial ALL insertion. The femoral origin is approximately 50% of the AP distance from the posterior femoral cortex and slightly distal, 3.7 to 9 mm to the Blumenset line, and that the tibial insertion is approximately 50% of the AP distance from the anterior edge of the tibial plateau. The function of ALL. ALL function as a secondary stabilizer to ACL when it resists the anterior translation and internal rotation of the tibia. ALL does play a role in the anterolateral rotational instability of the knee joint. Yay, we have reached to the end of this video. See you in the next one. Take care and bye.